Hello, my name is Carl. I am a paediatric emergency medicine doctor. Today, we are going to talk about acute behavioural disturbance. An important principle before we begin: verbal de-escalation should be plan A, B, C, D, and E. Restraint and sedation are always the option of last resort. Over the next 10 minutes, we are going to consider the following. Acute behavioural disturbance is best thought of as a descriptive term rather than a diagnostic entity in its own right. It is usually manifest with mood, thought, or behavioural changes and can either be transient, episodic, or long-lasting. It can have either a medical or psychological cause and may reflect a person's limited capacity to cope with social, domestic, or environmental stresses. Illicit substances can accompany an episode or can be causative. Rarely, acute disturbance can involve threat, actual violence, destruction, active self-harm, and on occasion extreme physical overactivity. It is telling that the Royal College of Psychiatrists recommends 1. Acute behavioural disturbance should never be used as a diagnosis or cause of death. 2. The description severely agitated person in distress might be a better alternative. And 3. That training on this topic should explicitly recognise the scientific uncertainty surrounding the historic concept of acute behavioural disturbance. Let's consider this historic context now. In the not so distant past, the term excited delirium was often used. It referred to a state of hyperarousal and agitation, typically described in adult men, and was thought to represent a rare but dangerous condition. These adult men were thought to have hyperadrenergic autonomic dysfunction. Their hearts were beating faster, they felt as if they were overheating, and appeared to have a near constant level of overactivity. This triad was believed to be associated with a high risk of rapid deterioration and cardiac arrest, thought to be due to a combination of metabolic acidosis, hypothermia, and cardiovascular collapse. Historically, these cases were often in the context of altercations with law enforcement. These cases were described as being hyper-aggressive, having bizarre behaviour, and being impervious to pain. Typically, there was stimulant abuse such as cocaine, methamphetamine, PCP, and LSD. As a consequence, whilst differential diagnoses exist for acute behavioural disturbance, such as heat stroke, sepsis, neuroleptic malignant syndrome, head injury, this triad continues to signal a potential impending life-threatening emergency that needs sedation, intubation, ventilation, and cooling. This is the context on which adult care is based. Pause now to read this account from doctors in 1985. Of course, children are different, but how are they different? As it turns out, older adolescent patients are similar to their adult counterparts. They have a similar differential diagnosis and pose similar management challenges. Drug intoxication, for example, should be high on the differential. However, cases of the previously described triad are very rare and have not been described. What about younger children? Pre-adolescent pediatric patients are unlikely to have similar causes to those that affect adults. Here, verbal de-escalation remains the mainstay of care. If restraint is required, brief restraint is more likely to be successful, as opposed to the case in adults. The causes in this age group we will come to shortly. So how common is this in children? The United States literature suggests the number of pediatric A&E visits for mental health or behavioural health emergencies has increased from 7.7% of visits in 2011 to 13.1% of visits in 2020. The number of these cases are increasing. When Australian health professionals were asked how many children with mental health or behavioural health emergencies were visiting their departments, the following results were found, showing that it was not unusual for as many as 5 or more young people in some form of crisis to be attending their emergency department on a regular weekly basis. So, what are the causes for acute behavioural disturbance in children? I would like to use the metaphor of a water balloon. The balloon represents the child's resilience or predisposition to exploding. Risk factors include male sex, history of abuse or victim of violence, adverse childhood experiences, communication barriers, recent aggression, especially in the last 24 hours, missed medications, head trauma, neurodivergence, conduct disorder, looked after status, and previous incarceration. All of such risk factors make dysregulation more likely. The water that fills this balloon, potentially to bursting, represents potential stresses. When enough accumulate, the balloon bursts. Physical stresses include drug ingestion, intoxication, metabolic derangement, and pain. Of course, psychosocial stresses are more commonly the cause of the water balloon bursting and can be either acute or chronic. Medical conditions, first of all, include encephalitis, seizure disorder, metabolic derangement, hypoxia, pain, drug intoxication, and more. Behavioural causes include exacerbation of distress in those with existing intellectual disability, autism, or other disorders. Then there are mental health conditions such as psychotic disorders, mania, anxiety disorders, borderline and antisocial personality disorders. And finally, other factors such as situational crises, impulse control disorders, and a person having an inability to effectively communicate. An important takeaway is that children with autism or intellectual disability account for 44% of all incidents in this particular age group. Children who had a diagnosis of anxiety, depression, ADHD, or a history of aggression or self-harm were also most at risk of behavioural dysregulation. Here we see the numbers of children and the proportions of cause. Primary mental health and behavioural disorders are dominant. Medical causes are in the minority. There is also a slight predilection for females over males, unlike in the older age groups. Here we can also note that the median age is 14. So how do we help? The first step in helping is by putting on your own life jacket first. These are situations that need you at your best. You need a calm head and a thoughtful approach. Next time, In part 2, we will be discussing some case examples and talking a little bit more about acute behavioural disturbance in kids. Thanks for listening.